can have cataract surgery with just proparacaine or tetracaine on board. It's rare, just because patients do tend to be a little bit more nervous. So we tend to kind of pair topical anesthesia with some medicine that we give under the tongue that kind of just relaxes them. And it's a mix of various medicines, but it doesn't provide any additional anesthesia to the eye. It just kind of mentally relaxes them and allows them to kind of handle surgery a little bit easier, but they are awake during surgery, like cataract surgery. But for the most part, we don't just do drops only. It's drops plus like an oral sedative, and but they'll still be awake. If we need a little bit more anesthesia, so the case is longer, we're doing more eye manipulation. Some examples would be like if we're doing penetrating keratoplasty or a cornea transplant, or we're doing like a Yamani where we're suturing a lens in the eye, then we will do more advanced anesthesia. So the patient will still be awake, but they'll have IV medicine that relaxes them even further. And then we'll do a retrobulbar block, and I'll talk about what each of these blocks are. And that really just allows us to achieve more anesthesia. That's not just the cornea, but also numbs the eye muscles and the lids and the vision as well. So that's kind of the next level of the anesthesia that we can provide. And then the most aggressive anesthesia that we can do is general anesthesia. And that's kind of the more common thing that you think of when someone's getting intubated. We're helping them breathe with a machine because they're so sedated. We have to kind of provide that additional ventilation support. Of course, all of this is done by our anesthesia colleagues who are wonderful at what they do. But very, very rarely will we use general anesthesia, especially for like anterior segment cases or the case that we most commonly do at Vance Thompson Vision. Some exceptions will be, if we have to take a patient to the hospital and they're severely demented and can't follow directions during surgery, that might be a candidate for like general anesthesia, where we just need them to be able to be still during surgery and kind of tolerate surgery. Retina surgeons tend to use general anesthesia a little bit more, and big oculoplastic orbital cases that tend to happen more kind of in academic medical centers, those also tend to use general anesthesia. Far and above, most of our cases are topical plus that oral medicine that we use, and then a smaller subset we use local regional anesthesia at Vance Thompson Vision. So some of the anesthesia blocks here, I would say the two main ones, and like I said, this is just providing additional anesthetic support around the eye, so a little bit more than drops, is this retrobulbar block, a subtenons block, and a lid block. So the retrobulbar block and subtenons blocks are fairly similar. The retrobulbar block does provide a little bit more anesthesia. And here is kind of a picture of a patient getting the retrobulbar block. They're introducing a needle kind of under the skin, and the trajectory of the needle is intended to kind of go behind or under the eye into this little space here and inject medicine, and it kind of coats this eye, and it actually affects patients' vision. So if you ask patients to see something after surgery, they're not going to be able to do it. It anesthetizes the optic nerve. They can't blink and they can't move their eyes. So it really kind of provides a lot of local anesthetic. That's why when patients get this type of block, we'll put a little patch and shield on them afterwards. So if you're doing their post-op day visit the next day and you see that they have a patch and shield, it's probably that they got this retrobulbar block. And the reason that we do that is because they can't close their eyelids, so we don't want them just kind of sitting there with their eye open all night, just kind of, and then they can't see anyway. So we just go ahead and patch it down and just kind of help them as it wears off. It takes about 24 hours to wear off. So sometimes patients will have a little bit of difficulty with their vision if we see them 12 hours later, just because that medicine's still on board, but it will eventually wear off. And then here's a little video of a subtenons block, similar to a retrobulbar block, but we can do this kind of under the microscope. And sometimes like patients don't need to be quite as sedated for it, but the anesthetic effect is a little less robust than a retrobulbar block. Here's a quick video. Like I said, if you're squeamish, whenever I'm pressing play, I'm probably showing you a real video. So they're just using some scissors here to kind of cut down on that clear conjunctiva. And then they're just introducing a blunt cannula with some medicine, and I'll talk about the types of medicines. And they're just kind of injecting that into that space around the eye. You kind of see that the conjunctiva is getting a little chemotic or kind of rising up a little bit. And so that medicine is kind of achieving that. And this is just a series of a bunch of these subtenons blocks. So again, they're making that little opening in the clear conjunctiva. They're not going into the eye. It's a very superficial layer. And they're introducing a blunt cannula and putting in some medicine there. And you see kind of that chemosis. You see all that medicine. So that's how we get them a little bit extra numb. Like I said, we don't use these blocks for typical cataract cases. These are for longer cases that have more eye manipulation involved. And then lastly, you can do a focal lid block where you're just kind of numbing the eyelids or kind of the basically like the facial nerve. So if a patient has something called blepharospasm where they're kind of like winking a lot, this is a way to kind of stop that process so that we can do surgery on them. Very rarely do we just use a lid block only for cataract or anterior segment surgery. Oculoplastics uses it obviously much more frequently. And then the anesthesia, so we have injectable anesthetics that we can use here. So most commonly we'll use lidocaine or bupivacaine. Another name for lidocaine is xylocaine, and then another name for bupivacaine is Marcaine. The differences in those medicines is just really how long they last. Bupivacaine has a much longer half-life, so it lasts for much longer. We can mix these medicines with bicarb and hyaluronic acid so that they burn a little less and last a little bit longer. So sometimes the block will be a mix of these medicines, not just the anesthetic, but have some other components to it. And then often, depending on what we're doing, it might be paired with epinephrine. If we're doing a block around the eye, we don't because we don't want the basically vessels that are feeding our optic nerve to constrict. So we don't want that to clamp down. So we don't, subtenons and retrobulbar, we do not use epinephrine. But around the eyelid, if we're just doing something more superficial, we can use epinephrine, and that's just to clamp down those vessels so that it's not bleeding as much. We're going to talk just briefly so we talked about how do we get the eye ready before we start the surgery, and that's making sure patients are as comfortable as possible. The next step is actually prepping the eye. So our great circulators do a nice job of making sure that the eye is clean and sterile as much as we can get it through like a process that they will do. And then once they do that, our scrub techs will be gown and gloves. So that means that they're sterile, and then they will drape the eye with this plastic drape and then use an eyelid holder to hold the eye open so we can do our surgery. I'll take a break here for just a second before I go into instrumentation. Any questions pop up that I can help answer? I don't think so. So I'll just keep going. So instrumentation, lots of different instruments that we use, and different surgeons prefer different instruments. There's many different ways that you can do cataract surgery with many different instruments. I'll talk about kind of the most common ways that we do cataract surgery, but just so one surgeon might do it differently. Even here with NBTV, there's a little bit of variability between surgeons as to how they do things. So a speculum helps open the eyelid. I'll show you some pictures. A forceps holds things for you. So kind of think of it like some tweezers. Scissors, of course, cut things. You can have blunt scissors. You can have sharp scissors. Blades are kind of like a scalpel. They will also cut things for you, just depending on what you're trying to cut. A blade or a scalpel, or sorry, a blade or a scissor might be better. Suturing kind of sews things together, as you're familiar with that. A needle driver holds that basically needle and suture so that you can kind of drive that into the tissue that you're needing to approximate together. And then the phaco handpiece is what we use for cataract surgery. I'll show you some pictures of it and then talk about why it's special. And then we have an INA, which stands for irrigation and aspiration handpiece, and that removes the cataract or the cortical component of a cataract. I have to sneeze, so I apologize. Excuse me. Okay. So the speculums, we have all sorts of different types of speculums. It just kind of depends on surgeon preference or the type of surgery that you're doing. But these are what we can kind of considered wired versus like a solid speculum. And this has kind of some blades on there that are blunt. Spring versus adjustable. So these are kind of spring loaded. So once you put it in, it'll kind of like rest in a natural position versus an adjustable has this little knob here that you twist and it'll gently open, and you can kind of titrate it to how open you want the eye. And then there are also small versus larger speculums, meant for adult patients versus pediatric patients. And then at the bottom here, this is a special speculum that we just rarely use. It's if we want to reduce as much pressure on the eye as possible. This is one used for like pretty delicate situations. We don't often encounter it, but that is a different type of speculum available. For the forceps, there's all types of forceps. There's smooth, there's tooth, there's serrated forceps, and then within tooth forceps, the teeth are different sizes. So oculoplastics tends to use like 0.5, which is a larger tooth size, versus if we're doing more kind of ocular surgery and kind of manipulating tissue like conjunctival tissue or Tenon's tissue, we tend to use something like a 0.12, which is smaller. It's just telling you how big those teeth are. And jewelers are kind of these like sharp little tweezers here. They don't have any teeth necessarily like this one here. They just allow you to kind of do some fine work. We just tend to use these in clinics. We don't tend to use them intraoperatively. And then there's these specialized forceps down here that you can use for either tubes that you're doing for glaucoma or cornea transplant. So these forceps, there are plenty different types that we use for various situations. And here we have a kind of picture of various scissors that we also use. They all have fun names like Vanis, Westcott, Stevens scissors, right-handed cornea scissors, left-handed cornea scissors. And these are all just basically scissors that are really designed for different use cases. So we have some small little scissors that we can cut corneal sutures versus Westcotts are a little bit bigger scissors where we can do a little bit larger work around the conjunctiva. And then like Stevens scissors, those tend to be like larger ones that we can use for kind of like more macro surgeries. And then these scissors down here is what we use to kind of do a full thickness cornea transplant. All right. And then we'll talk a little bit about these blades. So in addition to scissors, we have blades. This is the 11 blade. The way that I like to remember is kind of makes a 1 here. So you can kind of trace that and it's a 1. And then the 15 blade is that rounded. I don't have a great mnemonic. Maybe it's like the belly of the 5 or something like that. But these are kind of an example. There's like 10 blades and things like that. But these are the two most common ones that are used in ophthalmology. And these blades are used for oculoplastics, really. We don't use blades of this style in intraocular surgery. We'll use microscopic blades that we can see down here. There's something called like a 15-degree blade. There's a 1-0 or a side port blade, a keratome. These are all smaller, more kind of precise blades that we use for our kind of microscopic surgery. But then we also have instrumentation that we need for suturing. So we'll have needle holders. There's all sorts of fun ones too. Like I've kind of the theme, oculoplastics has bigger, needle drivers, needle holders versus if you're doing intraocular surgery and you're closing conjunctiva or sclera, you'll use smaller needle drivers just because the sutures that you're using are also smaller as well. There's locking and non-locking, which means that when you press it down, it stays together and closed versus if you press it again, it'll click it open and then will just allow you to kind of manipulate the forceps like you need or the needle holder, sorry. And then non-locking means that it doesn't matter if you close it or open it, it's not going to get stuck. You kind of have full control of the process that it's doing. And here's just kind of a little picture of a suture. If you look at a suture packet, I don't know if you ever kind of come across one, but it has all this data on it and it means different things. It'll be what is the needle shape like? How much of a curve is there on the needle? Is it a half needle or does the needle kind of get truncated and it's just this part of the needle? Well, what does the needle tip look like? Is it spatulated? Does it cut in a reverse way? Is it tapered? So there's all this information on a needle packet. And just depending on what you're trying to do, you might need different needle types to make that process as effective as possible. In addition, there's lots of different materials. Really, we kind of divide it in absorbable and non-absorbable, which means that if it's absorbable, your body will take care of it. Non-absorbable means that you need to have it removed. So Vicryl, for example, is a common absorbable suture that we use, and that's more for like conjunctiva, laceration repair, things like that. Non-absorbable is more like Prolene that's typically used in like oculoplastics cases. And those need to be like removed afterwards. It's like the blue type of suture that you tend to see. So yeah, lots of different options, and those little needle packets give you lots of information as to what your needles do. They come in all sorts of sizes. So surgeons who do kind of more body surgery tend to use needles that are like in the 2.0, 3.0 range. So the smaller the number, the bigger the needle is, which is a little counterintuitive. In ophthalmology, we tend to use between 6.0 to 10.0, 10.0 being the smallest, and that's what we use for cornea surgery. And to give you an example, the sutures that we use that are 10.0 nylon in a cornea transplant are smaller than human hair. So it's really tiny sutures that we end up using for those surgeries. So some best practices for the assistant in surgical cases is just kind of preparing, knowing the steps and the instruments needed. There's lots of ways that you can kind of do this. One, talking to colleagues. So whenever there's a new scrub tech training, or there's a scrub tech training a new scrub tech, they'll be there coaching them, letting them know, okay, this is what they expect to be handed next. This is the next part of the surgery and kind of how to prepare for that, how to set up their trays and all of that stuff and what each instrument is used for. So they'll often have, orientation and guidance for that. The next piece is there's something called the doctor's preference list, the DPL. So for every surgery, the doctors kind of write out, these are the instruments that I would like to use. This is the steps that I tend to do it in. And then they can kind of refer to that. If it's maybe a surgery that's not done as commonly, there's kind of like a resource to look back and say, okay, this is how we need to set up for this case, based on the doctor preference list. At Vance Thompson Vision, I think they tried to do a nice job of making it fairly consistent between all the surgeons. So there's not as many things to manage. But there's like a binder that has all this information up in the OR. And then lastly, YouTube is a great resource. And sorry, it should have said R, not it is. So YouTube is a great resource. There's, like I said, there's variance in techniques in terms of how people do surgery, but it can kind of give you an overall picture of, hey, how are we going to get from point A to point B in this surgery? And so it's just a phenomenal resource to kind of look at surgeries and kind of see what is entailed. Follow sterile technique. And so, usually it's kind of like shoulders to waist that's considered sterile. And so once you have your gloves on, you really can't touch anything outside of that range. And then, of course, anything that you can only touch things that are considered sterile. Keep the space organized, handle eye instruments with care. They're very delicate and can very easily be bent or misshapen. And sometimes it can be hard to fix and they're very expensive. So just kind of be delicate with that. And then pass instruments correctly. So, orient them in a way that they're about to be used rather than kind of having the surgeon kind of have to grip it in order to use it successfully. And then handing them in a way that you're not stabbing someone, yourself or somebody else. That's always safety is kind of number one there. All right, so that's kind of the overview. I'm going to jump into kind of some of the specific surgeries that each subspecialty has. And then after that, we will wrap up, but this will take a little bit of time as we go through all these subspecialties. Any questions before I move along? No pressure if not. It sounds like we can go on. And thank you, Isaac, for your blessing. I appreciate that. All right, so we'll start with some oculoplastic surgery cases here. Almost every subspecialty has a mix of laser procedures and like OR procedures, including oculoplastics. They will do some lasers as well. I didn't include them in here. I'm not as familiar with them, but they have some clinic procedures that they do and then some operating room procedures. So we'll go through kind of a smattering of these to just give you an example. So epilation, so here's the jeweler's forceps that we kind of showed you earlier. It's just kind of pointed at the very tip. It's for just grasping little things that we have to. And so this is really helpful when we're just trying to take off misdirected lashes. So that procedure is called epilation. We're just pulling lashes that are rubbing or bothering a patient. Eventually, if a patient needs to have lashes epilated over and over, there is like a more permanent way that we can kind of, damage the follicle essentially so that it doesn't regrow if a patient needs that. But if you just kind of need a temporary solution, just pull that lash out. You can just do it with these jeweler forceps at the slit lamp. So it's a great way to provide patients some immediate comfort. Some patients will get chalazions. So these chalazions are kind of like these red, angry bumps. They really bother patients. Ideally, we treat them conservatively, but sometimes they don't like to resolve and just kind of are persistent and stubborn. And so if that's the case, we can excise this gland that's kind of backed up and isn't able to kind of release its natural material. And these are some of the instruments that we use. So these are all kind of considered chalazion clamps, and these are curettes. So these kind of have like it's almost like a spoon. And so you use this clamp to isolate the chalazion, and then you use that spoon after you've kind of used a blade to open it up to kind of just clean out the space and drain all that stuff that has backed up. So here's some pictures of that process. So they've already made the incision here and place the chalazion clamp around it. And so now they're just kind of expressing that material out of it. And then now they're using that spoon to really kind of clean out the inside of that area, just make sure that there's nothing remaining. And then that's kind of what it looks like after they're done. Probably this is a couple of days afterwards. And you don't typically have to do any stitches. And you can either do this on the outside or you can flip the lid and drain it from the inside. It just depends on where the chalazion is sitting, what your approach will be. Obviously, doing it from the inside causes a little less scarring. And so here's the before and after for that patient. You can also use steroid injections to treat chalazion. So there's different ways that you can kind of treat that. But this is a good example of an oculoplastics procedure in clinic. Placing plugs, everybody does them here. And so those plugs, you can just place them at the slit lamp. Here is what your puncta looks like under the slit lamp. And then we'll put a little probe to basically enlarge that drainage system. Here's a schematic of that drainage system. Are you able to see my mouse? Sorry, I'm not sure. I bet people can't turn on their audio, but Jamie,
we can. I can
you
see your
can.
mouse. Yep.
Okay, perfect. So this is just like a little schematic of the punctal system. So we're just trying to put a little plug here so it backs everything up. And so this is the process of putting that plug in. So we've kind of made that puncta a little bit larger, and now we're just putting that basically a stopper in that space so that tears stop draining and kind of coat the eye and give it as much nutrition as possible because our natural tears are typically the best thing that we can use. Another thing that oculoplastics providers can do is kind of what we consider like a probe of the nasal lacrimal duct system. So again, we'll enlarge that puncta, and then we will use these little cannulas that we put on a syringe to kind of flush into the system. And if we have reflux and the kind of reflux that we have, it can let us know if there's an obstruction at different points in the system. So before here, we're trying to stop the system, we're trying to back it up. But sometimes people naturally have some stenosis or scarring in their system, and it's too much. They're like, tears are draining down their face. They're saying, I'm just sitting there and tears are rolling down my cheek. Well, we want to see, well, is there an obstruction here that's causing tears not to drain correctly? And so that's how we can assess it. We flush it, see if there's any reflux. And if there is, and there's different ways we treat it, kind of depending on where it is and how much it's bothering the patient. One way that this can be treated, again, just depending on various like clinical aspects, is what we call like a DCR, where we basically create a new outflow for tears to drain rather than like our natural system. That's a doctor-assisted rhinostomy. So blepharoplasty is another term for kind of it's like an eyelid. It's a surgery that's intended to help with droopy eyelids. Typically for just an isolated blepharoplasty, especially in the upper lid, you're just taking kind of superficial skin tissue and kind of taking that excessive tissue and then closing it back up so that patients have less drooping. There's cosmetic and then there's medical. So some patients get such droopy lids that they have trouble seeing in the top part of their vision. And then some patients just have a little bit of droopiness, but it's actually not affecting their vision. They just don't like how it looks, and that would be more cosmetic. So insurance can cover, the medical blepharoplasties if it's affecting your visual function, but if it's just cosmetic, obviously they're not going to cover that. An ectropion repair. So there's the term ectropion and entropion. I don't know if you've heard that before, but ectropion means that your lower lid is, or upper, but it's typically your lower lid is drooping out like this. So rather than being nice and flush on your eyelid, it's kind of hanging out. That can be for a variety of reasons. There's scarring, just age related, paralytic. There's all sorts of different ones. But if you are having some ectropion, there's different ways to repair it, but typically it involves kind of tightening the lower eyelid. And so here's a picture of this patient in their post-op period. You can kind of see that they have some sutures taped down there. And then here's their after picture far after surgery and kind of how nice that like lid margin is sitting against the eye compared to kind of where they were before. So they can do really beautiful work. And then the entropion is the opposite. So in is kind of how I think about it. Entropion, the eyelids roll in. Also different reasons why patients have it. So it's a little hard to appreciate in this photo, but I don't know if you can kind of see that lid margin is rolled in there. And so again, different types of procedures that you can do. It can either be some quick sutures that kind of roll out the eyelid, or you tighten the lower lid. But then hopefully this is kind of the post-op result that you can achieve so that those eyelids are kind of nicely sitting and symmetrical between each other. This is a picture of a child actually who has what we call ptosis, which is lowering of the eyelid, and it's typically related to muscle rather than having too much skin. So too much skin is called dermatochalasis. Ptosis is that the muscle either is fibrotic or not as functional, and so it's that lid is hanging lower than it should. In children, it can be for a variety of reasons, but some children are just born with a droopier lid. It's congenital ptosis. And so, or it can be traumatic. There's all sorts of different reasons, but this is a repair photo of a patient who had, ptosis before and now has this beautiful symmetrical outcome. And I won't talk too much about the steps just because, again, it can be pretty varied from provider to provider, but I will talk about steps for other surgeries. And then this is a nice example of an eyelid laceration repair. So this is what we call an eyelid margin involving laceration. So when it involves the margin, it's a little bit more complicated to repair. Typically, you want a specialist to repair it. And so that's, when we get calls from the emergency department, it's because, now it's involving this margin. And so they want it to come together nicely. So they'll call us to fix that. And so here is a patient who's had lid laceration. And now this is their post-op result, which is really beautiful. Whoever did that did a nice job. And then oculoplastics will take out lesions, lumps, and bumps, whether they are concerned that it's cancer or the patient doesn't like it, it's irritating them, or they just don't like how it looks. And so they'll take those kind of lesions. Sometimes they'll just kind of shave it off. Sometimes they'll cut it off. And sometimes they'll actually have to make a larger opening in order to bring everything back together kind of more cleanly. And so here you can kind of see that they have this defect here, but it's kind of healed nicely with time. And here's some examples of other lesions. So this is kind of a little bump. It looks benign. I don't know for sure based on the picture, but given how large actually they've done this repair, I wonder if maybe they were concerned that it was something more neoplastic. So anyway, so this is the kind of repair that they've done in order to take this out. You can kind of see the area that they've worked on is larger than the area that was involved, but they do that to have a better cosmetic result. So sometimes they need to kind of shape and reform tissue in order to kind of make everything come back together nicely. And this patient had a beautiful outcome after that. Here's another example of you have this kind of little lesion here, which I bet this was some sort of cancer that they were concerned about. And so they've kind of drawn what they expect them to do. They're going to do some rotations in order to kind of get everything to close nicely. So again, this looks larger than the lesion involved, but this is kind of the way to get a nicer cosmetic outcome so that the contours and everything look appropriate. And then here's an example of a skin graft for a lesion. So they took off this lesion, and in order for it to not cause some ectropion, because it's too short here, what they've done is they've put a little skin graft in that area that they've taken out in order to make sure that there's not too much tissue loss and there's shortening of that eyelid. And so beautiful outcome as well here. And then they'll also take out eyes. So they'll do enucleation procedures, and that's unfortunately, some patients will lose vision to the point where they have a blind eye for whatever reason, and they can become painful. Having the eye removed sometimes can be a great benefit for those patients. It sounds morbid, but it really can improve somebody's quality of life if they have a blind, painful eye. It's a really, a wonderful resource for the right patient. And so they'll have their eye removed, and then they have a specially made and specially designed prosthetic for their eye so that it matches. And so you can kind of see here that this patient's natural eye looks more cosmetically, looks worse than her kind of prosthetic that's been designed for her afterwards. You almost can't tell that she's had an eye removal surgery. And so they do really amazing work. They're these artists do these prosthetics that are fantastic. And sometimes you can't tell that someone's had an eye removal surgery. And then this is the last procedure that I'll talk about for oculoplastics. It's something called an optic nerve sheath fenestration. This is a very big surgery. It's very delicate. Not everybody does it. But I don't know if you've heard the term idiopathic intracranial hypertension or pseudotumor cerebri, when there's too much fluid around the brain and it's transmitting pressures to your optic nerve. If it's a very severe case that's progressing really quickly and needs immediate attention, and medicines are not going to be enough or they're not doing enough, this is almost like an emergency surgery that's done, and they'll create a tiny little cuts or window on the optic nerve, kind of like basically the thing that wraps around it to allow fluid to outflow and relieve some of that pressure off the optic nerve. It's a very delicate, and I feel like of all the surgeries that I've seen oculoplastics people do, this is the one that I feel like they kind of sweat the most on, just because it can be pretty delicate. I'll quickly go through some strabismus surgery. Strabismus surgery is eye muscle surgery. That's the other term for it. And there's all sorts of fun things that you can do, but really the main two subtypes that you think of are recession and resection. The way I remember is recession, I'm relaxing the muscles. So if a muscle is too tight, I'm going to recess it. And so like a economic recession, it's kind of things are down. That's what we're trying to make things down and relax. And a resection is tightening things. So if a muscle is too relaxed and we want to tighten it up, we're going to resect it and shorten it. So here's the surgery has multiple steps, but a resection, ultimately the goal is to kind of take this muscle from where its natural position is and put it back a little bit further, because if it's back further, it's not going to work as well. And that's what we're trying to do. We're trying to weaken that muscle. If it's too tight, if it's turning your eye in or something like that, that kind of helps realign your eyes. And then a resection is the opposite, where we're trying to kind of tighten things up. We're trying to make things stronger. So we actually kind of advance that muscle a little bit forward or cut off some of the muscle and bring it forward. So it's a shorter lever arm there. All right, we're going to jump into cataract surgery. I have a video for this one. It's probably my longer video. I think it's like 3 minutes, but I think it's really helpful. Let me just go ahead and mute that. But if you haven't seen cataract surgery before, I think it's just great to watch it to kind of understand what patients go through. So I'll increase the speed here and I'll kind of quickly narrate it. So here they're putting some medicine to numb the eye and dilate it a little bit more. They've made a little small 1 millimeter incision here. Now they're putting some jelly called viscoelastic in the eye to stabilize the eye. and they're making our main incision here. So this is the incision where we use our primary instruments to kind of do our surgery. So now he's using what we call capsular rhexis forceps. He's making a little opening on the front part of the cataract here. And so that opening, he's just making a nice circle opening. And once that's done, he's going to introduce his instruments to break up the cataract. He's just basically prolapsing the cataract out of the bag here, so that it can rotate and come out pretty easily. So here's that instrument. So this is the phacoemulsification handpiece. It uses ultrasound energy to break it up. He's using a slightly different technique than we use here. And so this is a kind of a horizontal chop that he's using, but he's just taking out that cataract there. And that's ultrasound energy that's coming from that metallic tip that's breaking it up into little pieces and kind of sucking it in. So this is the nuclear component of the cataract that he's putting into his handpiece. He's almost done with that. He's going to take out his phacoemulsification tip, and now he's going to put in his INA, which will now take off the cortical component. It's a gentler instrument. We don't want to pierce the posterior capsule. It becomes a much more complicated cataract surgery if we do that. So when we don't need that sharp instrument, we try to kind of switch over to a nice plastic round tip instrument. So that's what he's using here. He's just kind of taking all that cortex. And then he's going to fill up the bag with jelly again. We want that bag to be inflated where that cataract was before. And now he's going to put the intraocular lens. So this is the monofocal or the multifocal or the LAL. That's kind of where that lens fits and sits in that bag where he's just taken out that cataract. And now he's just going to take out that jelly, all the kind of stuff that we were using in surgery to protect the cornea, keep the eye stable. So he's just kind of taking all of that out with vacuum. And this next step is just hydrating our incisions. So as you know, we typically don't use sutures in our cataract surgery, and it's because we can just use water, like high pressure water in those incisions to kind of swell the cornea and kind of have those incisions clamped down. Here are just some visuals of that process because I know that was pretty fast. I just don't want to take too much time. So here's that incision that's made, and then that capsular rhexis that's used to kind of make that opening. And so here's kind of a side view of that, where here's the colored part of your eye, and then here's the cataract. And so we're just really working on that very front part of it. And then that's that phacoemulsification, the ultrasound energy that's used to break up that cataract. So just a couple of different views. And then that cortical removal with the INA tip. And now it's kind of that lens insertion here into the bag. So here's kind of seeing where it ends up. It's behind that colored part of the eye and the natural bag that we all have. We try to keep that because it makes the lens a lot more stable. And so here's that lens sitting in that bag complex. So sometimes patients will get something that we call posterior capsular opacification or opacity. It's just little cells that kind of migrate towards the back of the lens. So some patients will be like, I love my vision after cataract surgery. It was amazing. But over the past few months, it's gotten blurry and I just don't feel like I see well. It feels like my cataract's coming back. It's a little bit of a misnomer because it's not the cataract coming back, but some people do call it a secondary cataract. And that's just haziness of that, the bag complex that I said that we like to leave in there. So it's just that bag getting hazy because those cells migrate to the back. And so here's like a drawing of it. Here's an actual picture of it at the slit lamp. And here's another picture. And what we use is we use something called a YAG laser. So it focuses energy into the back side of that bag. And we just try to open that bag up. It's stable at that point. Things have scarred and settled. The lens is much more stable. You don't want to do this right after surgery because that bag hasn't kind of shrink wrapped yet. But a couple months after surgery, totally fine to do. And it'll help patients, improve their vision. And typically they'll see better in a couple of hours or the day after that YAG capsulotomy. And I have a video here, super fast, but here's that laser, just kind of polishing that. And you can kind of see the difference. I'll go back to that here, but here's that fuzziness. That's the opacification now that's clear. So he has kind of lasered off that bag, but keeping the lens intact. And so that's what a YAG is. All right, we'll move on to refractive surgery. We have all sorts of refractive surgery. There's a ton of things that have been tried in refractive surgery that we don't use or have fallen out of favor. So I'm trying to keep it to kind of things that we are using still and a little bit more familiar with. So lumbo relaxing incision is just when we make a small partial thickness cut into the cornea. We're not going full thickness. And it just basically allows for some astigmatism correction. And the way that we do it here typically is with femtosecond laser. So the machine upstairs before cataract surgery will actually make these incisions automatically for us at a certain depth in a certain location based on their IOL calculations. And it's just to treat small amounts of astigmatism by kind of allowing that part of the steeper cornea to relax there. RK, people don't really use that anymore, but you'll see patients that have had RK before. And so again, these are partial thickness incisions of the cornea that were used to treat kind of higher levels of myopia before. And then Intacs has fallen out of favor, but we use CTACs now. So you should hopefully be familiar or have heard that term. But Intacs used to be a plastic kind of uh, almost like a little plastic sleeve, if you will, that we would tuck into these tunnels that were made in the cornea. Now we don't use that. We don't use the plastic for a variety of reasons, and we actually use natural cornea tissue that's donated and is prepped by another company. And so they are just safer and have a better profile and better outcomes. And so that's what CTAC is that it's cornea tissue and not plastic. And so here is a picture of somebody who had Intacs, the old type of CTACs, and you can kind of see those plastic segments here. And that's usually for keratoconus or patients who have like severe steepening that needs to be flattened out. And LASIK is another refractive surgery that we do. I was thinking of putting a video, but it would probably be a little bit longer. So, but essentially there's a laser that's typically used to kind of make this flap here on the cornea. It's usually 110 micron flap. It's really, really thin. And then once we do that flap, we lift it up. We just kind of shine a laser that's programmed by the machine based on information that we input. And that laser treats very, very, very precisely. And so that laser reshapes your cornea to get you out of glasses. And so then that's basically the whole procedure. And then we put that flap back down. Some patients will get PRK, and that's for a variety of reasons. We tend to prefer LASIK if we can, but sometimes people are not a good LASIK candidate. Either their corneas are too thin, um, maybe they're in a profession where their flap might just get dislocated or high risk for trauma in their eyes. So PRK might be a better option. And we actually don't make a flap for this. We just kind of basically rub off the epithelium and then we treat the cornea and then that epithelium regrows. The reason people don't like PRK as much, there's a couple of things, but one is it's just painful to recover from versus LASIK. People typically feel like they can go back to work, the next day or day after. But it's a great option for people who are in a good candidate. Another type of refractive surgery is something called a phakic intraocular lens. So this means that we're leaving your natural lens and we're putting a new lens implant. So EVO ICL is probably what everyone's most familiar with. And it's really kind of an implantable contact lens that's permanent is the way to think about it. So this is an animation of that. And so here's just a patient getting some numbing drops. This is kind of the shape of the implantable contact lens. They make an incision like cataract surgery. They slide it in. They will tuck these little arms under the colored part of the eye, and they just hydrate those incisions and come out of the eye. And this obviously makes it look extremely straightforward. It is a fairly straightforward surgery, but just takes a little longer than 30 seconds. Not too much longer, but just a little bit. And another type of phakic intraocular lens is this, what we call like iris enclavated lenses, where it's actually pinching the iris and that's how it stays there. Not as common anymore. Verisize is the brand name for that. But that kind of used to be a type of like implantable lens that we would use for patients that didn't have cataracts, but needed, some type of prescription correction. And then cataract surgery, of course, there's a refractive, cataract surgery that you can do. Either patients' cataracts aren't as bad, but they are losing some near vision, and they want to be able to see vision at all distances. So that would be a refractive lens exchange. Or their cataracts are, medically ready to come out, but they want to have as much independence from glasses as possible. And so this is where like a multifocal lens or an LAL can come in. And so that's considered refractive surgery it's because we're trying to get them out of glasses as much as possible. Move on to some cornea surgeries here. Common ones, penetrating keratoplasty, a PKP for short, DMEC or DSEC, which is where we strip part of the inside of the cornea, and then a pterygium, which is like a growth of the conjunctiva. So here's just a cross section of which each of these cornea transplants are. So a PKP is a full thickness. I like the way Dr. Kramer describes it. He says it's like a manhole where you just kind of taking out that manhole and then you're putting a new one in and you're suturing it in. A DSEC and a DMEC are partial thickness. The difference is kind of the tissue that you're including and how thick it is. So DSECs tend to be a little bit thicker, and then DMECs are these thin tissue transplants that we do. And lots of reasons why we'll do a penetrating Plasty most commonly now is really if patients have like significant visual scarring, or if they're having an ulcer that has perforated and they need an emergency cornea transplant surgery to kind of stop that hole that has been created. And so, just kind of briefly, some pictures, and I will show a video of this as well. So again, if you're squeamish, maybe not the video to watch, but they basically punch out the front of the cornea, that clear windshield, and then we'll use scissors to kind of totally take it out. We'll also punch the cornea that has been donated, and then we'll sew that cornea on. And so here's kind of a little drawing of that. Here's some pictures of patients after they've had cornea transplant surgery. So these are interrupted sutures and these are running sutures, not as common anymore because we're not doing it as much for patients who have keratoconus, which that tends to be the more common suture that you would use. Anyway, here's a video of a cornea transplant, very, very fast. Cornea transplants usually take, 45 minutes to an hour and a half. So this is, 2 minutes, obviously a very different fast version. So here they're, taking off the tissue that they're trying to remove with a sharp kind of punch. So he's outlining that. He's preparing his tissue. So this is the donated tissue here. And now he's actually going to kind of use this Treefine to take off the cornea. And so it's basically kind of spun around. And so that's kind of, making the incision that you need on the cornea. And then they're going to use some scissors to remove that cornea button here after they kind of inflate the eye a little bit. And so he's just kind of seeing if he's got that nice. I'm going to kind of fast forward it a little bit. And they're just kind of stabilizing their eye. So now they're using cornea scissors to go ahead and cut off that front cornea. So they're doing that. So now the cornea is about to come off here. This is a very delicate part of the surgery. It's risky, so you want to get that new cornea tissue on as soon as possible. So he's kind of saying the window of vulnerability. The eye is completely open to the outside world. So here's that transplant or that donated tissue. He's going to kind of go ahead and lay that on top of the eye. And now he's kind of suturing that donor cornea onto the eye. And then eventually you'll either get 16 or 24 sutures, depending on how large the cornea transplant is. So I won't kind of go through all of this, but they're just doing, placing all these sutures individually. Oh, sorry about that. Let me go back here. Okay, so that's a cornea transplant there. Oop. Okay. And then that's a full thickness cornea transplant, or a PK, a partial thickness cornea transplant, a DMEC or a DSEC, where you're only transplanting the most inner lining. So this is just like a couple pictures of a DMEC surgery, but you remove the inner lining. So you're not removing the manhole. You're keeping the cornea, the top surface. You're just taking off the inner lining. And then you put in a cornea transplant in the eye that's stained with this is why it's blue. They stain it at the eye bank. And once you put it in, you tap it out. And once you like that kind of flattened configuration and it's in a good spot, then you introduce this, like this is what we want it to look like before we introduce gas. And then you put gas under the transplant to kind of elevate it and have it stick to the area that you need it to. And so that's why we have patients lay on their back after surgery, because we want that gas to kind of push up that transplant and start that vacuum function and that pumping function that it needs to do in order for it to. We're almost done-ish. I think we have maybe a little bit more here. So a pterygium, we talked about that last time. It's kind of this basically overgrowth of congentinons under the cornea here. People who tend to work outside are a little bit higher risk for it. And so we can remove this for patients if it's irritating, causing irregular astigmatism, or if we're concerned that it's maybe not benign. Most of the time pterygiums are, but sometimes they can be, we wouldn't call it a pterygium at that point, but sometimes it can be like a cancer. And so we would have a different name for that. But if any of those reasons, we can remove that for the patients. This is after it's been removed. And now they're harvesting some conjunctiva superiorly so that they can cover that area that they've kind of opened up. And now they've glued it down to that area. And this looks like, oh man, that eye looks very irritated and uncomfortable. But in 2 weeks, it'll look beautiful. So that kind of heals up very nicely.
Well,
So,
Dr. Morales, there is a
yes.
question. There's two questions. One in the
Mm-hmm.
chat says, what condition in particular would cause the need for optic nerve surgery?
Mm-hmm.
And then the
So,
second one will ask about How does all the aqueous come out of, or sorry, does all the aqueous come out of the eye during a PKP? How do
Yeah.
you maintain the anterior chamber pressure, preventing the posterior segment from prolapsing through the hole?
Yeah, great questions. So for the optic nerve surgery, the optic nerve sheath fenestration that I mentioned, where they do a little slit to decompress, kind of that basically too much pressure that's being transmitted to the optic nerve. So it's called IIH or idiopathic intracranial hypertension. It used to be called pseudotumor cerebri. So that if you've heard that term, that's what it is. But IIH is the term for it, and it just means that you have high pressures from your CSF or your cerebrospinal fluid being transmitted to your optic nerves. Most often, there's not, we do an evaluation to make sure that it's not because of a scary bad thing going on for a patient. Like it's not like cancer that's causing high pressure in the brain or something like that. If we've called it IIH, that means that we've ruled out the scary things. It's just that you have high pressures. We don't have a reason, but you have it. And often it's associated with like significant sudden weight gain or hormonal changes during pregnancy. They believe that there's some tie with hormonal changes. And so that's when people need an optic nerve sheath fenestration is if they have that thing, what I've called IH. And then whoever asked about BPK, that's a great question. You're thinking like a surgeon, really. And what we do is so when they've done the little outline of what they need to cut, we'll make a little stab incision. We'll put viscoelastic, that jelly, in the anterior chamber before we fully open it up to allow like a heavier thing to hold things back. A lot of the aqueous does end up coming out from the front part, but we're trying to kind of keep things as stable as possible with that jelly that we put in before we open it up. And so once that's fully taken off, we're trying to not manipulate the eye too much because if we are, we're putting pressure in places that we don't need to be putting pressure on. And so that can cause things to prolapse. The dreaded complication of well, many, but really what makes our stomach sink is something called a suprachoroidal hemorrhage. When there's such a pressure differential between the eye and like the outside, you can basically get bleeding from the very back that then starts pushing everything forward and it can be expulsive. Extremely rare that that happens in a cornea transplant, a full thickness cornea transplant, but because we know that the critical window when it can happen is when the cornea is totally or the eye is open when we've taken out the cornea, we work really quickly to suture a new cornea back on. You kind of like feel everybody getting silent and working really quickly to get like 4 good sutures in place so that we can restabilize the eye. So the eye is unstable at that point, but we try to be as gentle as possible and do as little manipulation. And far and above, it's a very, very rare complication. It's kind of something that doesn't happen that often, but it is something that we have to worry about. So okay, I'm going to keep going because I think I answered both of those. Glaucoma surgery. So, like I said, we'll have lasers and surgeries for most subspecialties. The lasers for glaucoma surgery are going to be an SLT or a PI or a diode, is what we call it. And then surgeries, we have MIGS, which is minimally invasive. We tend to use like iStent Omni here, but there's lots of different ones. Then there's a Zen and TRABs and a tube shunt. We don't do TRABs here. They do them in Omaha. And so we'll go over these really quickly here and I'll show you some examples. Okay, so this is the SLT. So we use a little mirrored lens to kind of help direct a laser to the angle here. And so that laser is intended to be directed to the drainage system of the eye and stimulates outflow to the eye. We, the leading theory as to how it works is that it stimulates an immune response to clear out some debris kind of in microscopic clogs of the drainage system. And so it's not permanent. We're not putting an implant or anything in the eye. And so this is actually a picture of ALT, but SLT is very similar. We don't use ALT as much, but and then this is a PI. So we'll use a laser to basically make a little cutout punch of the colored part of the eye. So we'll use this for DMEX to prevent pupillary block. And we'll also use them for patients that we feel like are narrow and at risk for having what we call acute angle closure. And so this helps basically create a safety valve for fluid to flow out in a different way so that their pressures don't like spike up and cause problems. So I think I have a picture of or a video of a PI. Yeah, I put it out of order, so I'm sorry about that. But here's a quick picture of a diode. And we don't use this as much here, but for patients who have end-stage glaucoma, where maybe their vision is not very functional, but they have high pressures and it's bothering them, then we can do this diode where we basically laser the ciliary body to stop aqueous production. It just basically just kind of lasers it to try to shut it down and calm it down a little bit. We don't like to use it on patients who don't have a severe glaucoma because it can cause a lot of inflammation. And that can cause like vision changes. So this is more for patients who have maybe like a more painful eye that just need a little bit of additional comfort there. So here's a quick video of the PI that I mentioned, the peripheral iridotomy. So here's the laser, and then I don't know if you kind of saw that there. There's just a little flash, and then they're going to do it again. In just a moment, they're going to make it a little bit larger here. I'm just going to go back here. So, oops, sorry. There is their laser. They're focusing the laser beams here. And then once they find that spot, they're going to just shoot it. So you're going to see a little flash once they shoot it, and then you'll see kind of the little hole that they're creating. They can vary in size, but as long as it's open, that's kind of the most important thing. So, sorry, I thought I marked. Yep, there it is. Okay. All right, we'll keep going here. So tube shunt, this is a more aggressive glaucoma surgery, but has a better reduction in pressures for patients. And so they do end up having an implant sutured to the white part, the sclera of their eye. It's typically tucked under the eyelid, so you can't see it, but it is an implant. And then that plate here has a little tube that extends out and goes into the front part of the eye. And so that basically creates a new drainage pathway for patients that have, difficult to control glaucoma and need more aggressive, basically pressure reduction. And then a trab is our most aggressive glaucoma surgery that we have. And like I said, we don't do it here. It's done in Omaha, but it is basically an option where we can kind of punch out a part of the colored eye and then make a new flap here to kind of create outflow, a new drainage pathway. That's what we're trying to always do, is just kind of create a new drainage pathway, turn down the faucet or make that drain a little bit bigger or better, or reroute it in order to help patients with pressure problems. And then retina surgery, I'm going to fly through this. I'm not a retina specialist, and we don't do retina surgeries for Evans Thompson, so I'll just be a little bit fast for that. But laser surgeries, that's always the breakup here. So there's lasers that you can do for a variety of pathology, either on the macula or in the periphery. And then for surgeries, there's all sorts of indications, whether it's diabetic disease, somebody's had a retinal detachment, if they have what we call an epiretinal membrane. So you'll do surgeries for those. Here is an example of a laser that it's not as common anymore, but they'll do a laser to the macula if people have wet macular degeneration. Much more common now is using anti-VEGF medicine to treat macular degeneration. But it used to be kind of treated with this focal laser is what we call it. Same thing with diabetic macular edema. They used to use these focal lasers. The injections are much more popular now than that. And then PRP, here's a quick video of it being done at the slit lamp. So you can kind of see them firing all those little shots. They might be hard to see, but you kind of see a little whitening happening in the retina back there. So they're just firing lasers on the retina. And it's really intended to deaden the peripheral retina to stop an inappropriate response that the body's trying to basically have to recruit blood vessels in areas that it shouldn't have. But unfortunately, that's what diabetes does, because it basically is very damaging to your normal vasculature. Your eye feels oxygen deprived. It releases these signals to try to say, hey, I need some oxygen, make any blood vessels that you can. Those blood vessels are very fragile, very unhealthy. They can break easily and cause lots of problems. And so by doing this peripheral laser, we try to kind of stop that process, stop that recruitment of those bad blood vessels that cause all those problems. And then retinal detachments are typically treated with surgery. There is some exception where they'll just do they'll something called a pneumatic retinopexy in office, but there's certain criteria that you need to meet to be a good candidate for it. But a retinal detachment surgery, they'll typically take out that jelly of the eye. They'll make a little hole, kind of suck out the fluid that's causing that retinal detachment. They'll tack down the area where that retinal detachment started with some laser, and then they'll either put air, gas, or silicone oil, depending on what they're hoping to accomplish, to kind of tack everything back and reoppose it to its natural anatomy. And so here's just a little cross section of the vitrector and the light pipe. I like to think about it as a microscopic laparoscopic surgery. So they have a little light here. Their camera view is here, and then they're using this vitrector to kind of take out all that vitreous and all that jelly from the back of the eye. And then a scleral buckle is where they kind of suture a band on the outside of the eye to bring the eye closer together. to help reoppose the retina to the back. And that's just done, there's different indications for it, so I won't go into that. And then here's a retinal membrane peel. So some patients will have a little scar tissue over their macula, cause some distortion in their vision. They can actually go in and peel it off. It's a very delicate surgery. And then kind of hopefully help with some of the symptoms that patients are having. Those are all my slides. I'm sorry, I know it's a long presentation because I'm the only presenter, so I apologize that you had to hear me for an hour, but hopefully it was useful and you learned something. I'm happy to answer any questions.
So good. There was one, somebody asked what your favorite surgery to do is.
That's such a good question. I would say I think it is still cataract surgery just because it's so beautiful, it's so elegant. It's just there's not a lot of surgeries in medicine where you can like really give people back more independence than what they had before surgery. And with like these advanced technology implants, you can really just make someone's life great if they are good candidates for it and really reduce their need for glasses, which is a lot of fun. I would say my second favorite is probably, I would say a PKP, just because the suturing is really like it's very precise. It's really it's like when you're done with it, you're like, this just looks beautiful. But it is a longer surgery and we don't do it as often. But I would say that's maybe my second favorite surgery. I'd have to think on that one.
So
Anything else I
cool.
can help with?
No other questions in the
Okay,
chat.
awesome.
If there are any additional questions, you can email the doctor support email address and we'll be sure to pass them on and get answers for you. But thank you, everybody, so much for joining us for week 2, and we'll see you back next week.
Okay, awesome. Thank y'all. Have a
Thank
great day.
you. Bye.